Hi students. We are starting with the lecture of plastic surgeries. It's not limited to only cosmetic procedures, okay? It is also dealing with reconstruction and restoration of the tissues, following the trauma or injury like burns, any congenital defects, any infections, and that is what the plastic surgery is dealing with. Okay, for a physiotherapist point of view, it is important because although the surgery will restore the structure, but physiotherapist will have to restore a function. So in that way. Now, if we see the burns, it is considered as a severe type of trauma because they affect not only the skin but also the entire body system. Okay, that means whatever the part has been affected with burns, the whole function of the surrounding structures will be affected. So burn injuries, okay, it will cause massive fluid loss. As we all know, there's a burn, so fluid loss will occur. Infection will follow. Metabolic stress will be there in that area. If at all, if the burns are severe, that may cause a long-term disability. So that's why the patient requires a prolonged multidisciplinary management. Definition wise, it is burns are a tissue injuries which will caused by thermal, chemical, electrical, or a radiation. Okay, these injuries can lead to a partial or a complete destruction of the skin and underlying tissues. Burns are classified as a severe trauma because of the high risk of the shock, infection, and a long-term functional impairment. Okay, so that is what is burns look like. As you can see in the figure, the severity and the affected areas into a dermal area. The last one, the red color in the uh, red color here, as I'm just able to, yeah, this one is muscle. Okay, so this is what is uh, the last layer where the muscle will be affected due to burns. Now let us look at the pathophysiology. Whenever a burn occurs, a tissue damage will be divided into three zones. What zones? Zone of coagulation. Okay, that means it contains a dead tissues. Zone of stasis. That means whatever can be restored, we can do that. It's salvageable, meaning it can be preventable, or it can be reused, or it can be used for the restoring functions. If at all, if it is treated early, then only. Okay, then zone of hyperemia. That means it usually recovers, and early physiotherapy will correct the positioning, edema control, help prevent the zone of stasis and progressing to irreversible damage. So that is what it the meaning. So the zone of coagulation is the highest one, severe one. Slide 5. This is related to the classification of burn. The burns are classified by the depth, as we had seen in the second last slide, that skin. So by depth into the superficial, partial thickness, full thickness, and fourth degree burns. That is the even the bone can be visible in those type of burns. Superficial burns involve the only epidermis part of the area because the nerve endings are still intact, so it will be very much painful. Partial thickness burn involves dermis and forms the blisters. Okay, still there will be pain. Full thickness burn destroy the entire dermis area, and they are usually painless because the nerve destruction will happen. So that's why it will be a painless, but it is a severe one compared to the first one. And fourth degree is it burns will extend into the muscle or bone, and it always require a surgical involvement. It is non trainable or anything, right? So burn extent is calculated using the rule of 9 that you might have learned it earlier during the earlier semesters, but we just have a look at it. Rule of nine is had to be understood. Okay. So the extent of burn determines the severity. So we can calculate as per the area involved in the burns. So fluid resuscitation and prognosis, it will also depend on that. Larger burn areas will increase the metabolic demand and rehabilitation will have a challenges. Classification of the burn. So there are many types of burns. Thermal, the most common one, hot burns. Electrical, chemical burns, radiation burns, friction burns. Okay. Electrical burns often have a deep tissue damage with a minimal skin injury. Chemical burns have a continue to cause damage until it neutralizes. That means suppose example is acid. Okay. And understanding of that causes help in the medical and physiotherapy planning. Right. What are the complications of burns? Early complication include the shock. Okay. Airway injury will happen if at all if there's an inhalation burns. That means any kind of poisonic fumes which have been inhaled. Okay, electrolytic imbalance, severe pain, infections, reduced chest wall compliance, reduced chest expansion, increase the risk of pulmonary complication, and that would be needed because of that would be needing the physiotherapy because of these um, issues on the respiratory system as well as electrolytes deficiencies, right? Late complications. Late complications are contractures, hypertrophic scars, keloids. Keloids are nothing but after a deep wound, there will be a black color formation of tissues that hardens, and that is called as keloid. Joint stiffness, muscle wasting, psychological issues. These are the complications which are directly affecting the mobility or quality of life. Now, principles of the management. Burn. Burn management includes a primary survey using A, B, C, D, E. That means airway, breathing, circulation, disability, and exposure of the burn area. Fluid resuscitation meaning we want to replenish the fluid, whichever the loss is there, we want to replenish those fluids into the tissues. Pain control, wound care, infection prevention, nutritional support, early rehab. These are all the necessary steps that has to be taken. But consider the early physiotherapy and rehabilitation program introduction, which will reduce the complication and improve the functional outcome. Sinoplasty. So we are moving towards the another topic. It is a minimal invasive procedure, okay, where it is related to the sinuses of the head. Though it is not a major reconstructive surgery, but it is relevant because the sinus conditions or sinusitis affect the breathing, it will affect the posture, it will affect the sleep quality, it will also affect indirectly exercise tolerance. Okay, so which will have a challenges during our physiotherapy. So let us understand sinoplasty. It is a minimal invasive procedure, as you can see in the figure, where the balloon catheter is used to dilate a blocked sinus opening. Normally, sinus anatomy is preserved and the drainage is improved. Unlike traditional surgery, there is a minimal tissue is removed during the sinuplasty procedure. It's a minimal invasive surgery. So with the natural opening of the nostril, it can be done. So we should understand that there's a preservation of anatomy, meaning it will have a faster recovery. Indications of spinal sinuplasties are chronic rhinosinusitis, recurrent sinus infection, nasal blockage, failure of medical management. These patients often complain of headache, facial pressure, breathing difficulty, and fatigue. So breathing dysfunction will automatically will have a response to a reduced capacity of doing exercises. What are the principles of procedure? Balloon catheter will be inserted into the sinus opening. Then the balloon is inflated. that would widen the passage. Once the balloon lead dilation happens, that means once the pathway is dilated, the balloon is removed. That means the balloon is deflated again and it will be removed from the natural path. And that allows the normal muscle to, normal mucus to drain. This procedure is quick and it is preserving the tissue. That means there is no cut or something. So we had earlier learned about the angioplasty, right? Consider that one as a sinuplasty. The complications. What are the complications? Complications can be mild bleeding, facial discomfort, temporary nasal congestions. Serious complication may be rare, but maybe a conventional sinus surgery can be required when the complications gets severe. That means bleeding is more or something. Okay. Let us understand what physiotherapists can do. So physiotherapy will be focusing towards the sinuplasty in terms of the breathing re-education, and that will have to give us appropriate breathing exercises to during the recovery phase. Now let us focus towards the tendon transfer. It is a very important reconstructive procedure, okay, especially in the hand. Those surgeries required at hand due to injuries or nerve paralysis, conditions like leprosy, those conditions we require a tendon transfer. Okay, so whatever the movement is lost, we can give it to, we can restore into the patient. Definition wise, it's a surgical procedure in which a functioning muscle tendon, the part of that tendon unit is redirected to replace a function of the paralyzed muscle, and it does not create a new power. It redistributes the existing muscle power. So that is what is uh, tendon transfer called as. Indications of tendon transfers are, as we already understand, that it is irreversible nerve palsy. In those cases, we can do nerve paralysis or muscle paralysis. Sorry, muscle paralysis, leprosy hand, post-traumatic deficits of hand, certain congenital conditions. Goals are to restore the useful function and to improve the hand mechanics. That is what is the indications. Okay. Principles. What are the principles? For a successful tendon transfer, the donor muscle must be strong enough. Adequate excursion should be there. Excursion meaning movement. The straight line of pull should be having those muscle. Whatever the donor tendon is there should have a tendon muscle pulling capacity with a straight line pulling should be there, and preferably perform a single function. Those only donor tendon can be taken which can perform a single function. Okay, so if a surgeon will ignore these rules and will take other tendons, okay, as a donor site, that will leads to poor outcome. Now, what are the post-operative care? Let us consider the post-operative care. After the tendon transfer surgery, the most important step is the protection of the transfer tendon. So the limb has to be immobilized. The functional position should be achieved so that there is a minimal tension on the repair. We all should know by now what is the functional position of hand. If you do not know, please refer the Dina Gardiner, which will tell you what way the functional position of hand should be kept. Premature movement or stretching, which will lead to rupture or elongation of the transport tendon. Okay, so that has to be prevented. What should be the physiotherapy? Physiotherapy which will begin once the surgeon permits the movement. Initially, we focus on gentle activation of the transferred muscle. We are not right now in early phase, we are not focusing on strengthening. The patient must relearn a new movement first. That means because the tendon is from the another muscle. So whatever the current muscle transferred tendon is there has to relearn a movement pattern because the muscle is now performing a different function when than before. Okay, that is what is necessary. So the term plastic surgery that does not refer to the plastic material. It comes from the Greek word plastikos, that means to mold or to shape. And the plastic surgery is a branch of surgery that deals with the remodeling of the any part of the human body that has been damaged, lost, or deformed. In simpler words, this is the plastic surgery which focuses on restoring from the restoring restoring a shape and function, especially of the skin and its contents. Okay, let's move it to the next. It is mainly concerned with the replacement and reconstruction of the soft tissues. This includes the skin subcutaneous tissues, nerves, tendons, and blood vessels. The most important objective of the plastic surgery is not the beauty alone, but is to restore and improve the function. And this is where our physiotherapy becomes an inseparable part of the management after the surgery. So we must understand before moving to further that some terminologies are there. Cosmetic plastic surgery, that means surgery which is done mainly to enhance an appearance in the individuals without major deformity. Example can be a mastectomy. That means a removal of the breast tissues where a surgeon will re-establish and reform the shape of the breast, and that will give an aesthetic look to the patient. The second is graft. It's a bone, skin, or a tissue which is taken from one side and transplanted to the another side, where it survives and grows. The third one is reconstructive plastic surgery. It's a surgery designed to restore normal appearance and function of disfigured or impaired body parts. For a physiotherapist, a reconstructive surgery are far more relevant clinically, okay, than the other two. So the donor side is the area from the where the tissue or flap is taken, and the recipient side, as we know, it is the wound or a defect that needs coverage. The pedicle that refers to the blood supply of the flap. Okay. Therefore, improper positioning or excessively movement which can compromise the blood flow and cause a flap failure. Now let us understand the types. Okay. First of all, we will move to the next one, that we will start with the cosmetic surgery. Cosmetic surgery is a subspecialty that focuses on the enhancing appearance using surgical and medical techniques. It aims to maintain a normal appearance and restore it, or enhance it beyond the average aesthetic level. So, even though the cosmetic surgery is focusing on appearance, physiotherapy role may be little, but it is still there. That may be related to the postural correction, breathing, swelling control, and safe return to activity. Common cosmetic procedures include an abdominal etching, that means which contours an abdominal fat. Okay, abdominoplasty, that means tummy tuck. It is also a very famous term, tummy tuck. Uh, Blepharoplasty, that means it reshapes the eyelids. For abdominal surgery, physiotherapy must focus on the breathing mechanics, as abdominal muscles are closely attached to the thoracic segment. So that's why we'll have to focus on breathing for more. Along with that, posture, stability, trunk mobility, and the safe mobilization. That is our concern in this area. Mammoplasty, which we are talking now about the regarding the breast tissues. It includes a breast augmentation, breast reduction, and the breast lift. It is reduction is the breast reduction is often done not only for the cosmetic region but also for to reduce back and the shoulder pain. Physiotherapy, which will focus on the posture correction, scapular stability, shoulder mobility, and breathing exercises, and gradually functional recovery is achieved. Buttock augmentation, that may be done using a silicone implants, fat grafting. Chemical peels are used to treat an acne scars, wrinkles, and pigmentations. Though these procedures are dermatologically and cosmetically there, but physiotherapists will still be in a guiding point regarding the comfort, positioning, and the precautions during activities. Now, there are other surgical cosmetic surgeries are also there, like labiaplasty, rhinoplasty, otoplasty, and a facelift. From a physiotherapist point of view, knowledge of these procedures is important, mainly of the postural advice, swelling management, and safe return to the daily activities. That is what is we need. Okay, to know. Liposuction. Now, liposuction meaning removal of a fat. Okay. Chin and cheek augmentations are done using implant or fillers. Male pectoral implants are used to enhance the chest appearance. After such procedures, physiotherapy advice is focused on the posture, breathing mobility, and gradual activity progression. Reconstruction surgeries. Now we shift to the reconstructive, from cosmetic to reconstructive surgeries, which is more relevant to us. Okay, it is performed on an abnormal body structure to improve a function and approximate the normal appearance. These abnormalities may arise due to congenital defect, trauma, infectious disease, or tumors. Okay. It is commonly performed after burns, traumatic facial fractures, congenital anomalies like cleft palate or a cleft lip, developmental abnormalities, infections, after cancer surgeries, such as mastectomy. Okay, that is what is there. What is a ladder? Reconstructive ladder, it's a concept that guides a wound reconstruction from simplest method to the most complex. And the principle is to always use a simplest effective technique first and then move to more and more complex option only if necessary. The ladder, which provides a systematic approach to wound management. If one method fails, the surgeon climbs to the next level of complexity. This concept helps in rational surgical planning and rehab. What are the factors which influence the reconstruction? It is influenced by the patient factors such as motivation, general health, smoking, nutrition, donor side considerations, as well as the defect factors like size of the part, complexity, tissue loss, time available for the closure of the wound. Okay, so that is what is needed. Consider as a skin graft. Let us understand the skin grafting. Now we move to the skin grafting. Skin grafting it's done with when there is a loss of skin due to burns, trauma, any infection. The skin is taken from the other part of the body and it placed over the wound or area of wherever healing is needed. So what is skin graft? So let us understand what is the tissue expansion. Tissue expansion is nothing but whenever there is a reconstruction is needed and we are a shortage of any tissue like a skin. Let us take an example of a skin. So when the donor site is not sufficient to provide or harvest part of the body or just like a skin tissue, so in those cases, whatever the available tissues are there nearby to the wound area, that will be stretched up and then it is sutured. So that is what is tissue expansion. The examples are given here, like a hair bearing skin of the scalp that will be stretched towards the area where there is a no hair are there due to previous surgeries. Okay, so reconstruction is there after the breast deformities. So these are the common examples. So vacuum assisted closure. This is a special type of closure where generally we do it in a pressure sore condition where the pressure sore area is very deep wound and we need not we are supposed to seal the wound, but also we need to take care of the surrounding tissues functional status. In those cases, this vacuum assisted closure method has been done. So a wound like a pressure source where healing is really a challenge, in those cases there is a transparent tape which will be closing the wound first. Okay, and there will be a tube attached within the wound area, and that will be keeping a space vacuumed so that there is no to make sure there is an air seal tight, and to enhance healing, this vacuum assisted closure is done. Okay, so which will exudate the removal, that is one of the advantage. It will reduce the bacterial load because there is no any air, decrease the edema, and improves the blood flow. Now let us understand the grafts of skin. So there are three: split graft or a split graft. Let us talk about that. It is a split thickness graft which include the epidermis, part of dermis, and are commonly used in burns. Full thickness grafts include the entire dermis and used where the better cosmetic outcomes are required. Okay. There are other grafts also, like autografts. That doesn't mean literally a signature. Autografts are a same person or a same human or a same uh, body graft. If it is taken, then it is autograft. Allograft is the donor has given skin. Okay, the donor site of the body. Heterograft. Different species will give a graft. Donor donating the graft. And cultured skin, that means artificially made, cultured. Okay, it has been made, that skin. So cultured and artificial skins are almost same. So we should start with the split graft. These are the thin covered large areas and have a higher chances of the survival. However, they may contract more during the healing. These grafts are commonly used in burn patients. So that is what is called as a split thickness graft. Okay, they are thin, they cover large area, and they have a higher chances of survival. Full thickness. Full thickness grafts which contain entire dermis, that means the whole skin part, they provide better color match and cosmetic results that will require a well vascularized recipient site. They are commonly used in facial and hand reconstructions. Composite graft. Okay, so they are small pieces of tissues, and they will be having a blood supply to from the donor side, and they can be reattached to the adjacent wound, and this is what is composite graft. So you will understand that composite graft and what can I say, uh, uh, tissue expansion may look same, but make sure that you understand it better that this type of graft have blood vessels in those. Okay, so that is what is the thing. Okay, let us understand the advantage disadvantage. We had already discussed, but let us understand again. Split thickness grafts advantage are large area, donor sites heal spontaneously, and donor site can be reusable for the again grafting. Recipient factors are poor color match, easily abraded, that means detachable, inferior cosmetic results, and shiny structures and inelastic kind of materials will be formed. I mean, those kind of skin will be there. Full thickness grafts are smaller in area. Donor site must be closed. Donor site have scar. Recipient site are good color match. Abrasion resistant will be there. Good cosmetic result will be there, and a normal texture of the skin will be achieved. Now let us understand the flap. Okay, it's a piece of viable tissue which with a blood supply that can be used to cover an open wound to reconstruct the tissue effect defects. A flap can be created from the skin when its underlying subcutaneous tissue, fascia, or muscle, or even individually, any of those, or in the sum of the combination. That means, suppose skin with muscle, skin with fascia, muscle and fascia, whenever it is needed, those flaps, the whole thing can be attached. Depending on the reconstructive requirement, even a bone that can be included as a flap. Okay, so that is what is thing, right? Types of flaps: random pattern flaps, axial pattern flaps, local flaps, distant flaps, and free flaps. You consider this as just names, okay? You don't have to look into it. We will see into the next slide. See the random pattern flaps. There are no any pattern in giving flaps. As we can see, the donor site is connected to the donor area and also giving at the recipient site. Okay. These axial flaps are considered, it will have an artery, and if at all, if artery is long enough, so the flap has to be taken in that area, okay, of that whole area. So along with the axis of artery, I mean force of the artery, this flap is taken. So these are axial pattern flaps. Local flaps, as you have an example of nose area, okay. Transposition flaps, rotation flaps, these are the another types. Again, Z-plasty, we know this Z-plasty is used in reconstruction of the tendon elongation. Okay, wherever there is an equinus deformity in pediatric population, where there is a shortening of the tendon of calf muscle. So this Achilles tendon has to be elongated, and in those cases, Z-plasty is done. Okay, so these are some of the examples. Distal flaps, as you can see, the hand is attached to part of the abdominal groin area or to the foot. Basically, why this kind of flaps are given? Because the flap will be having a blood supply. Okay, so the live vital tissue will be able to heal very fast instead of just removing the whole flap and reattaching to the recipient site. These are the examples of the free flaps, as you can see. What is the aim of physiotherapy? Maintain the joint range of motion of both sides, that means donor side at the and the recipient side both, okay, to prevent the contractures and deformities. Maintain a muscle strength, and regain a maximum function of the patient, help the patient return to its active lifestyle within society, and prevent any complications. These are the aims. What can we do? Acute stage, consider prevent deformities, maintenance of range of motion, promote healing, protection of the site. Subacute stage, when a patient discharges from the home, maintenance of the range of motion and regain the range of motion, whichever is lost. This is the understanding of the burn. Okay. What happens during burn? If the burn is at the anterior neck of area, common contracture that we find is neck flexion. Okay. If the posterior neck of area, then neck extension. That would be contracting. I mean, the patient will remain in that position. If the axial burns are there, then limited abduction will be happening. If the anterior part of the elbow, that is cubital fossa, then flexion will be contracting. Contracture of the elbow flexion will happen. Okay. If it is in groin, then hip flexion will be there. Hip flexion contracture will happen. Back of the knee, that is popliteal fossa, then knee flexion contracture will happen. At the feet area, then depend on the feet. That means suppose in the front of the foot is there, sole is there, then there will be contracture of the toes, flexion contracture. Okay. Face area, depending on the variety, inability to open or close the mouth or eyelid. Okay. And these are the positions we can see for if at all neck flexion contracture, promote neck extension, in the other posterior neck, promote head flexion. Okay. Axilla, lying and sitting with the arm abducted, slings and pillows should be kept. Figure of eight bandage should allow a chest for a stretch in prone lying. Anti-elbow, elbow extension we promote. I mean, these kind of activities, what do? We do active movement, we do active assisted movement, we give gentle stretch, we maintain the end movement and count it and hold that position for a certain period of time, and again come back to the starting position. So immobilization phase after a reconstruction surgery. When a body part must be immobilized, it should be splinted and positioned in an anti-deformity position. That means contraction should not happen or tightening should not happen of that particular joint. So that's why anti-deformity position should be for a minimum length of time as possible. Some examples are given. Biological dressing, that means any dressing to wound less than 24 hours, that part should be immobilized. Okay. Autograft, then in those cases, at least 2 days. Split thickness, 3 to 5 days, and full thickness, 5 to 7 days. Okay, this is what is there. Now splinting. Categories of splint. Whenever those structures have been surgery is done, we'll have to provide a splint to those areas. Static or dynamic splints are there. That means static splints are certain kind of variables which will keep the position of that muscle or part or a joint in same position. It will not be able to move. Dynamic splints are while moving, those splints will be able to support a structure. Okay. The splinting can be supportive or corrective, as I told you, dynamic. It can be rigid or soft. The example is neck collar. We all know the neck collar. Suppose if the osteoarthritis of the um, those what can I say, vertebral column of cervical spine is happening. If it is at the milder level of osteoarthritis, that means degenerative changes are very minor, the soft collar is provided. If the degenerative changes are more and there is a risk of disc prolapse, then in those cases, rigid collar is given. Okay. Dorsal aspect and volar aspect splints are can be placed. So splints can also be available for the fingers, that is digits, hand, forearm based in those splints are available. Let's see. So precautions while splinting should be then whenever there is a splint, the perspiration will happen to that area. Okay, and it will lead to the infection. Okay, unnecessary use of the splinting may cause venous or lymphatic stasis. That means unnecessary pressure will be given to that area. Precaution must be taken to ensure the splint that do not produce a friction during use. Okay, that will break the tissue structures. Precaution that has to be taken to ensure the splint do not produce excessive pressure on any area of the use. Okay, and it should not be used in isolation, but as an adjacent to the treatment or regime. That means you cannot just wear splint; it should be a part of the treatment. It should not be a. How to manage edema? You elevate a limb. Okay, that's this is the splint you that you the sling, you can see it in image. That's a Bradford sling, which can be facilitating the elevation of the arm, and this is what is needed for the what can I say? Not the arm, sorry. It is for the foot, and this is what is needed to reduce the edema. Okay, every joint wherever possible, which will be moved through the full range of motion. If active exercises program must be advised to achieve that range of motion. Assisted active exercises is necessary for a damaged limb, and free active exercises are for the sound limb area. Sound limb meaning undamaged or vial area. Hourly exercises should be performed to reduce the edema, and that it does not consolidate, so that it does not consolidate or cause joint stiffness. What is the role of physiotherapist to subacute stage? Optimize the scar appearance, limit effect of the scar contraction, address to the prolonged bed rest. That means a person should be equally observed for that the patient is not remaining in the bed for longer period of time, that immobilization will also cause the atrophy of muscles. Active range of motion and passive range of motions. What is the frequency and duration recommendation? Physiotherapy intervention should be twice daily. For the sedated patient, gentle passive range of motion exercise should be done 3 times a day. And depending on the severity of the injury, active and very gentle passive range of motion exercises for the hand and fingers should be begun at the during it from the day of the injury. Okay. Now, what are the 5 principles of scar massage? Retrograde massage, effleurage, static pressure, finger and thumb kneading, skin rolling, ringing, and frictions. Okay, these are the techniques of massage. We had seen the circular massage, we had seen the friction massage, transverse massage. We had seen that in terms of that. We had seen the uh, longitudinal massage. Okay, we had seen circumduction massage, that circular massage technique we had seen. Then we had seen the central massage. Okay, so these are the things, and what can we see to aid venous return? These are the massage techniques. Okay, you already know the massage, which phase we should give massage. There are phases. Some massage technique has to be given during inflammatory, proliferative, and remodeling. As per that, we can give. What are the contraindication? Contraindications are compromised integrity of the epidermis, the open wound we are talking about, hypersensitivity to that area. Patient is having too much pain, cannot tolerate the therapy. Acute infection is there, bleeding is happening, wound is infected, and whatever the graft area is there, that is failing. What can we give? Aerobic training we should give as a general body exercise to improve the fitness, aerobic fitness, 3 times per week, three times per week at least we should give. Okay. Significant improvements once it is achieved, then it should be increased to the 5 times per week with the children case. The intensity should be 65 to 85% of the heart rate max. What should be type? Any type, okay. Whether it can be walk, it can be brisk walk, it can be running, it should be treadmill turning, it can be general ward walk. What should be time? The treatment should be done for more than 12 weeks. It's a 12-week protocol. 20 to 40 minutes should be per bout. That means per session it should be there. Resistance training to that general body also, and to the joint involved during for the surgery 3 times per week. Okay. Suggested that a break more than 48 hours must be given between the two bouts. Resistance exercise, that means alternate day we can perform. Resistance training that can cause a micro trauma to muscle already in a compromised state. So we should take care of that. Okay. And the burn patient stimulates the protein synthesis, and that is good for the patient. Okay. Type and intensity, as we had already discussed, this is for those who can understand the HR max. I hope in during physiology subject you had learned our heart rate maximal. So maximum heart rate can be counted as 220 minus age. There are other formulas which can be accurately measuring the heart rate, maximum heart rate. We will see it in the next semester. Right now, we should give any kind of intensity in resistance training at 50 to 60% of maximum heart rate. Okay, and it should be for at least progressing for after 1 week or maybe 2 weeks at 70 to 75% of the percent of the maximum heart rate. You can increase it. Okay, repetitions are 4 to 10 repetitions, and after the 7 to 12 weeks we can go for the 85%, up to 85% of maximum heart rate. Isokinetic exercises should be given 10 repetition, 150 degree per second, and using the 1 to 5 sets for the first 5 sessions, 6 sets for the 24th sessions till 24th session, and 10 sets. This is for knowledge purpose. Even if you just write isokinetic training, it's fine. Okay. At the end of the 12th week, what should we do? So important for the small range of motion movement, it keep the pressure superficial, avoid the sliding over the skin so that it can heal properly. Apply the pressure because it can cause the blistering. Okay, that is what is needed. Exercise for the graft and the surrounding areas. Joint and the muscle adjacent to the graft should be moved through their full range of motion as much as tolerated. Additionally, all the joints and the muscle should engage in a general full range of motion. Okay. Muscle near the graft lie over immobilized joints. Isometric exercises are crucial. So those muscles which are nearby to the joint, the isometric exercise should be given. And you already know, you can refer Dina Gardner for that. Respiratory care, what should we give? Suppose if your patient is having a secretion retention, then give the bronchial hygiene technique. If the patient is on a ventilator machine, then make sure that the collapse of the lungs doesn't occur. If the patient is non-ventilated, then you should go for the steam inhalation, beneficial to loosening the secretion, and it is good for um, uh, gas exchange. And breathing exercise should be given overall. Now let us come to the hand surgery. So now onwards, we are going to start with the hand, surgical hand, and that means we are going to talk about the critical traumatic hand related problems and leprosy hand. Both of them, leprosy hand and traumatic hand, that means hands, so injuries due to trauma and hand injuries due to leprosy. Okay, for both surgeries required. Okay, so we are going to mix with this. We are going to talk simultaneously. I'm going to talk on traumatic as well as leprosy. Okay, so let us talk about the hand surgery. Okay, which is aiming at to control the motor control. It is aim to restore motor control, sensation, and functional grip. And even the small injuries to the hand can cause a major disability. Okay, making a rehabilitation extremely important. So I'm going to talk about traumatic hand as well as leprosy hand. In the next slides, we are going to have leprosy hand related content. So in traumatic hand injuries and the leprosy hand nerve damage, which leads to the deformity such as a claw hand, surgery will correct the deformity while the physiotherapy restore a movement. Okay. So what are the things? Fracture fixations are there, tendon repairs are there, nerve repairs are there, skin grafts are there. So physiotherapy for the traumatic conditions include edema control, splinting, tendon gliding exercises, scar mobilization, sensory re-education will be there, functional task training are there, and rehabilitation is a precise and a function oriented. Okay, so this is about leprosy and very claw hand. Every one of us know ape thumb, that is one of the deformity happens because of the leprosy, and the wrist drop. Okay. So same things as of the traumatic hand, the surgeries are done, and the same kind of the physiotherapy we are giving. Now let us consider about the neck and the skin contracture. Okay, so the neck contracture, it is important to some extent. It is due to deep burns. Whenever it is delayed, there is a delayed wound healing or improper positioning of the neck, poor splinting will be given. So, physiotherapy is also not given much. So, the scar tissue will be formed gradually and that will tighten and restrict the movement at the neck region. Okay. So, what is the contracture's definition? It is a permanent shortening of the skin or muscle or the other connective tissue which will lead to the deformity and functional limitation. Okay, that is what is the contracture means. We had already talked about the neck contractures and everything, so this is just for knowledge purpose. Okay. What are the surgical things, contractures, surgical management? We had already seen about it. Z plasty are there, flaps are there, and contracture release surgeries are there. Right? What are the physiotherapy after a contracture? Optimal positioning. See, even if you do not know anything about physiotherapy, we should know one thing, that after surgeon has done a contracture release surgery, the limb or a joint has to be placed in that normal anatomical, but if at all, if it is doesn't come into anatomical position, it has to be in a functional position. That has to be there and should not be improper positioned. Okay, so that a physiotherapist role, and that will have to be checked. Customized splinting will be done as per the surgery. Graded range of motion, meaning we are breaking down into starting range, mid range, and end range. And this is how, as the healing takes place, we can start with the end range exercises. So that is graded range of motion exercises. Scar mobilization has to be done. So whatever the surgical scars are there, so it has to be mobilized later. And the long-term stretchings are needed. Okay, the stretching set has to be sessions has to be carried uh, even if the patient goes home. So what are the physiotherapy management in all kind of surgeries? Pain control is there, early mobilization is there, respiratory is very much needed, edema management is there, strengthening and functional training, patient education is there. So these are the books which you can refer.